Respected physicians and dear participants, welcome you all to today's sessions on management of acute MI. Today is our second session, or we can say part 2. We have with us our speaker, Dr. Azizul Hoque, consultant cardiologist, Division of Cardiology, Emory University of School of Medicine, Atlanta, USA. এবং স্যারের সাথে আজকে আমাদের মাঝে চেয়ারপারসন হিসেবে জয়েন করেছেন আমাদের বিডি ফিজিশিয়ানস এর একান্ত আপন এবং আমাদের বিডি ফিজিশিয়ানস এর গার্জিয়ান বলতে পারি আমরা ডক্টর রফিক আহমেদ স্যার। ডক্টর রফিক আহমেদ কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডিস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, ইউএসএ। আমি আর কথা না বাড়িয়ে, কারণ গতকালকে যেহেতু আমরা আমাদের স্পিকারের পরিচয় দিয়েছি আর রফিক স্যার আমাদের মাঝে আজকে নিয়ে অসংখ্যবার এসেছেন, আমি আর কথা না বাড়িয়ে আমি আজকের সেশনটি শুরু করার জন্য আমাদের সর্বজন শ্রদ্ধেয় চেয়ারপারসন ডক্টর রফিক আহমেদ স্যারকে আহ্বান জানাচ্ছি।
Good morning, Assalamu alaikum. So Aziz has been introduced already yesterday, but briefly, Aziz is a faculty at Emory University, assistant professor and a consultant cardiologist. He's a fantastic academician, and beyond that, he's a computer guru that a lot of people do not know. I mean, he's really professionally makes computers, but his passion is Bangladesh. I mean, there are few of us in America that we love to do things to the extent that last time we had a meeting in Bangladesh. People go to Bangladesh and then give a lecture, but Aziz went to give the lecture. That's the difference, and there are few of us. I go there, Dr. Chaudhry Hafiz Hassan. So I'm really proud to have Aziz here in the forum, and I would like Aziz to start his lecture.
All right. Thank you very much, Rafiq Bhai, for your kind introduction. And I would like to say that Dr. Rafiq Ahmed himself is one of my attending when I was in training in our residency program. So it's a very pleasure, really great pleasure to be with you and to be part of the BD Physicians program. So yesterday I talked about acute ST elevation MI, recognition and management, but it's a vast topic. So we decided to divide into 2 parts. Today, I'm going to talk about management of the complications of MI. Look, to start the talk, I'm going to share the screen. So, topic of this talk today, complications of STEMI that we talked about earlier. So I don't have any disclosure, no conflict of interest. So our learning objectives today to recognize the complications of myocardial infarction, and you should be able to select appropriate management strategies to treat these complications. And definitely as we go along, we'll try to give you the data, evidence-based data, how you could incorporate in our clinical practice. In our training programs, we expect our young physicians to know a few things for sure. They need to know how to assess hemodynamics of the patient, preferably at the bedside. They need to know the LV gram, how its correlation with the jugular venous pulse. Because certain situations like right ventricular infarct, tamponade, or acute pulmonary embolism, partially you could do the diagnosis on bedside because everybody will have elevated jugular venous distension. What's the difference? In tamponade, you do not have the Y descent. You lose the Y descent in tamponade, but in right ventricular infarct, it will be still there. So, and also we'll expect our fellows to know how to do the quick bedside echo. That's very important. Always put hands on your patients, listen to the patients, and look at the jugular venous pulse. You would be in better position to diagnose these complications of MI. Let's start with the case scenario, as I love to do that interactive sessions. A 68-year-old man with hypertension, cholesterol problem, brought to the cath lab with anterior ST segment elevation. And he received a drug-eluting stent with TIMI-3 flow. And on the angiogram also, you find that patient also had a 60% lesion in the right coronary artery. His blood pressure is okay, but, sorry, excuse me, his heart rate is high, 110, and blood pressure is low, 80/60. So it's definitely in hemodynamic compromise. So you start the dopamine at 8 mics per kilogram per minute. And after you deploy this stent, patient got TIMI-3 flow, but the patient still is on oxygen 3 liter, it's 90% saturation. You up titrate the dopamine and it's 15 microgram per kilogram per minute, but still not much effect. So you can ask the questions as which of the following next best step you can do for the management of this patient. So you're concerned about whether the right coronary, you need to put a stent in the right coronary artery. Maybe you didn't assess the artery very well. Should you put an intra-aortic balloon pump on these patients to give hemodynamic support? Or you want to go for the more durable LV assist device? Or even you want to go further for ECMO, or the patient needs urgent cardiac surgery. So if you look at the patient's situation, the patient's already on dopamine drip, you up titrated that. So still patient's blood pressure is on the low side. So he might need temporary mechanical support with intra-aortic balloon pump. And that might help you to support the cardiac output because he had significant LED lesion that is a large territory. So temporary balloon pump support might help him to go through the situation. So should he use the balloon pump and what is the evidence? As you see from the intra-aortic balloon pump SHOCK II trial, where there's about 600 patients randomized. And as we see the data from that, there's not much difference in mortality in 30 days. So balloon pump itself, if you do like randomly that every patient with low blood pressure or cardiogenic shock, just giving balloon pump, so it doesn't really do benefit the mortality in 30 days. But in selected patients, you could do. So it became, initially in the United States, we used to do everybody on balloon pump with some hemodynamic compromise. Then after the SHOCK II trial, the clinical guidelines came out that it's not class 1 indication, it's class 2A indication. And more mechanical support like Impella or other devices is class 2B indication. And actually in European guidelines in 2018, so routine use of intra-aortic balloon pump is class 3 indication. Yeah, we should use in selected patients, but you have to try first with vasopressor and other measures. If it doesn't work, then you could go for intra-aortic balloon pump support. Let's talk about complications. I generally like to divide that in 3 major groups. One group is mechanical, second group is electrical complications, and third group is non-myocardial. Like if the patient has like from aneurysm of the apex and they're getting clot formation and having a stroke, or the patient having post-MI pericarditis, we call it non-myocardial involvement. But main group, we need to focus on mechanical group. There's major dire situation happens in that group. So in the mechanical complication group, I like to divide into 2 major groups. One is unruptured complications, and the second group is ruptured complication. In unruptured complication, definitely you have severe LV failure. We call profound LV failure, cardiogenic shock. It could be from RV infarct. It could be from ischemic mitral regurgitation, LV aneurysm, or could be dynamic outflow obstruction. In the ruptured group, definitely, if you have papillary muscle rupture or septal rupture, free wall rupture. Free wall rupture could be either frank, tamponade, and patient basically immediate mortality if it ruptures totally, but it's contained within the pericardium. We call contained rupture, or sometimes we call pseudoaneurysm. So let's start with second case. A 51-year-old woman with hypertension, chronic kidney disease, came to the hospital in a community hospital, 3 days with intermittent chest pain and acute short of breath. Look at the blood pressure on presentation, 88/60, pulse is 112. Patient has elevated jugular venous distension, crackles in the lungs, cold and clammy. Look at that. Always touch the patient and feel the feet and hands. It's cold and clammy. The patient has low perfusion already. So these are the signs of low perfusion symptoms. Patient probably has cardiogenic shock going on. Patient have poor mentation. Patient might have low urine output. These are all of the symptoms of low perfusion or low cardiac output status. Definitely, an ECG is done. Due to the progressive respiratory failure, the patient underwent intubation and placed on pressure support, started on aspirin, heparin, and clopidogrel because of the ECG. Look at the ECG. The patient has ST elevation in anterior leads. And already Q waves formed from V2, actually V1 to all the way V4, the Q waves already formed, but there's significant ST elevation going. Patient still having angina. Patient underwent left heart catheterization. As we see, the LAD is totally gone, and the left circumflex artery has also complex disease. Right coronary artery also has very tight lesion down there and diffuse disease. And ejection fraction on this patient is 15%. Severely hypokinetic apex, anterior and anteroseptal wall. They tried to cross the wire through the LAD in the community hospital. They could not. And the patient decompensated. They put the patient on balloon pump and transferred to a tertiary center for further help. So patient came to your hospital, and what are you going to do? Okay. And here it comes very important concept that our major hospital in the United States, they have, we call a heart team. When a complex patient comes, the heart team include people from different specialty, like interventional cardiologist, cardiovascular surgeon, anesthesiologist. They all discuss those complex patients and they decide what's the best way to help the patient. So do you want to continue the medical therapy and pursue viability study? Because surgeons are asking, we don't want to do the surgery on this patient until we are sure the patient's anterior wall or apical wall are viable, they're not totally dead. Another concern, like aggressive interventional cardiologist might decide, okay, let's change the balloon pump with impeller, a stronger LVSS device, and pursue complete revascularization percutaneously. Or just another group of people are thinking about, okay, let's do the RC and left circ only, since LAD is already occluded, leave that alone. But you have to think about, that's the LAD that's causing the problem, it's cardiogenic shock. The RC and left circ has disease, but that's not the culprit vessel at this time. So you're not going to improve much the patient's condition. If you decide to do RC and left circ, it might deteriorate his condition. Or you might think about, okay, nothing much to do. Patient might need, in the long run, heart transplant. You might need to go for a durable surgical LV assist device because you expect that LV function will not recover. Or some very enthusiastic cardiologists want to take more risk. They want to, okay, patient has balloon pump, let's go ahead and revascularize with the balloon pump. But mind it, the patient might not tolerate because this very touchy blood pressure with this already on aortic balloon pump, and the patient has significant decompensation from the LAD territory, and revascularization might cause further compromise unless you have more stronger LV assist device. They can support with enough cardiac output. So the decision was to since the surgeons didn't want to take the patients, surgical risk is high. So we exchanged the balloon pump with Impella, and they decided to do for complete revascularization. So B was the answer that time with our heart team discussion. And as you see that the Impella was placed to support the cardiac output, and the patient had complete revascularization of LAD and SARC and RCA. And interestingly, the patient comes to your office 2 months later and do an echo. He walks in actually, his EF is 50%. So this is an example of cardiogenic shock, and sometimes you need to be aggressive how to manage these patients. It presents with low cardiac output, despite that they have adequate intravascular volume, rather they might have more volume that differentiates from hypovolemic shock. And they have signs of reduced perfusion. That could be mental status change, that could be low urine output and cold, clammy feet, as we mentioned above. And hemodynamic measurements you need to know about cardiogenic shock. Systolic blood pressure normally less than 90. And if there's a drop in mean arterial pressure from the baseline 30, that would also qualify for that. Normally they have more volume, pulmonary capillary wedge pressure is more than 15, cardiac index is low, less than 2.2. And they might have RV and diastolic pressure, if there's right side also involvement more than 10. So normally it happens in acute MI setting, most commonly in the anterior MI, and more than 40% of LV myocardial normally is involved, but it can happen also in right ventricular infarction. As you know that RV is a conduit for preload to the left ventricle. If RV is bad, you don't have enough preload to support the cardiac output on the left side. Definitely if there's myocardial rupture going on, that can also put you in cardiogenic shock. And different kind of arrhythmias, particularly sustained VT or VFib, or patient has severe bradycardia, that can also put you in cardiogenic shock. So what information we have in the scientific community and the data we have that we could follow some guidelines. The SHOCK trial that was published in 2003, they took about 302 patients, they randomized. They did emergency revascularization within 6 hours in this group, despite that they are being on either pharmacologic or intra-aortic balloon pump support. And another group, they have delayed revascularization, initial medical stabilization. And as you see from the SHOCK trial, that initial 30-day mortality has not been different much. Statistically, it was non-significant. But in 6 months and 12 months, there is significant statistical difference. Early revascularization was better. As we see that no mortality benefit was seen in all patients in 30 days, but if you do subgroup analysis in the SHOCK trial, if the patient is less than 75 years of age, they definitely benefited from early revascularization at 30 days and 1 year, but older patients did not. But overall mortality benefit was seen in 6 months, 1 year, and 6 years, because that happened to be in all groups after 30 days. So as you know, that cardiogenic shock is a fatal complication. It can occur in about 10% of acute MI, and the mortality is pretty high, 70 to 80%. So what should you do with these patients? And the SHOCK trial gives us guidance on that they should go for emergent PCI or CABG and revascularize these patients, and particularly the patients is less than 75 years of age. So our current clinical guidelines says it's a class 1 indication of early revascularization, either by PCI or CABG, for patients less than 75 years of age who are in cardiogenic shock within 36 hours of acute MI. Class 2A indication, if they are more than 75 years of age. But as you know, if the patient gets through that, their long-term, 6 months, 1 year, even 6 year survival rate is better. So then comes, like after cardiogenic shock, like severe LV failure. This is part of the cardiogenic shock. Definitely, what are the risk factors here? Age is a big risk factor, as we spoke about STEMI risk yesterday. If there's anterior MI, if they have diabetes, prior MI, 3-vessel disease, left main disease. And also very importantly, we learn that early use of beta blockers in large infarcts might put you in cardiogenic shock, and particularly if you give IV. When I was in training, the STEMI guideline used to say that we have to give IV beta blocker, and we knew that we are putting some patients in cardiogenic shock. That definitely had changed after the COMET trial. What the COMET trial is designed to give as much as beta blockade that they could do, really. They loaded these patients more than 200 milligram of metoprolol a day. That's a huge dose of metoprolol they gave. They gave 5 milligram IV every 2 to 3 minutes. Initial loading dose 15 milligram, then they give 50 milligram every 6 hours. The COMET trial showed, yes, they did decrease the reinfarction. They did decrease the arrhythmic death with, like if it's related to VT or VFib, but definitely they increased cardiogenic shock. That was published in 2005. And as you see that in the first plot, shock was much higher when the patient received, if the patient received beta blocker, they did worse. Okay, the placebo did better. But they did benefit with the arrhythmic death, as for example, VFib or other reasons. But overall cause of death did not change. But definitely metoprolol, IV particularly, and high dose metoprolol caused more cardiogenic shock. That's the reason in the new guidelines, we try to avoid high dose beta blocker in acute MI, and definitely no IV beta blocker unless absolutely certain that you need in certain situation when the heart rate is high and they have enough blood pressure cushion that you could give IV. Otherwise, do not give IV beta blocker in acute STEMI because it could put the patient to cardiogenic shock. Let's take another case. A 58-year-old man with hypertension, diabetes, came to the emergency room with 2 hours of severe substernal chest pain. Patient is in distress, diaphoretic, blood pressure is on the low side. And in the EMS, they gave nitroglycerin, and the ambulance personnel told you that the doc, his blood pressure dropped when you gave the nitroglycerin. When you examine the patient, make sure you really examine the patient. You see an elevated JVD and distant heart sound, but lungs are clear. It's a very important point. Lungs are clear, elevated JVD. The patient received aspirin, started on heparin drip, and is still having severe chest pain, 8 out of 10. What are you going to do? EKG shows there's inferior ST elevation MI. There's some ST elevation there in V1, maybe V2. But the question right now, when you examine the patient, you know that 1/3 of patients with inferior MI, they could have right ventricular involvement. So anytime the patient comes with inferior MI, try to get into the habit to do a right-sided ECG to make sure there's no RV involvement, because that would be huge implication how you're going to treat the patient. And the right-sided EKG is done the similar way you do on the left side. You do V1 lead on the left side, then on the right side you do V2, and then V3, V4, V5, 6 as you do on the left side. We did the right-sided ECG. Okay, still we see the inferior ST elevation, but look at that. V3, V4, there's ST elevation. That's diagnostic for right ventricular infarction. This is very important because you know that right ventricle is the conduit for preload that gives blood supply to the left side. So what are you going to do? Definitely this patient needs to do the cath lab. You already decided the patient needs to go to the cath lab, but is still having a lot of pain. Do you want to give sublingual nitroglycerin to this patient? Do you want to give fluid? Do you want to give morphine? Do you want to load him with metoprolol? As the COMET trial says, don't do it. You can do PO, but not the IV, but his blood pressure is already low. You don't want to give anything that can drop the blood pressure. Or you study on dopamine. That might be possible. But which one you should do first? You already diagnosed the patient with right ventricular infarct. The preload is impaired. So really the first treatment is going to be intravenous fluid. So give some more fluid, at least a liter or two minimum, before he goes to the cath lab. And definitely avoid sublingual nitroglycerin, because despite the patient is having pain, you should not give nitroglycerin under tongue on these patients with RV infarct. That's a take-home message here. Do not give sublingual nitroglycerin in any patient with RV infarct. Their pressure is going to drop and you can put the patient in cardiogenic shock. And we did an echocardiogram, and you see the RV is enlarged. There's a fluttering of the septum, we call septal bounce, the huge RV. And you did a left heart catheterization, and you see that RC is occluded proximally. And opened up with a stent, and you see the whole artery, and this is the RV branch. And the reason being, the right ventricular infarct happens. If you see right ventricular infarct, you already know that patient's occlusion is at the very beginning of the RCA, not after the RV branch, it's before the RV branch. This whole myocardium is involved, including the RV. So it's a very proximal RCA occlusion when it happens with RV infarct. Normally it happens with inferior STEMI in 33% of the time. So 1 in 3 inferior STEMI will have right ventricular infarct. So always do right-sided ECG. And definitely right ventricular infarct increases hospital mortality. But if you can push through and support the patient for a few days, you'll be surprised the patient turns around very well and long-term prognosis is very good. So when you have RV infarct, definitely they have more systolic and diastolic dysfunction. Acute ischemia causes that. And right ventricular systolic stroke volume drops, peak systolic pressure drops, and that subsequently drops the left ventricular preload and it drops the cardiac output. And the right ventricle actually dilates to slide up the stalling curve because the cardiac output is dropping. When it dilates, it further pushes the pericardium. And also, as mentioned above, not only systolic dysfunction happens, RV acute ischemia also causes diastolic dysfunction, and that further increases right-sided filling pressure. And you hear the right-sided S3. Listen to that, you might be able to hear that on the right side. If you see an acute chest pain situation, right-sided S3, you know that right ventricle is dilated. And dilatation of the RV, as I mentioned earlier, it causes pressure on the pericardium. That acutely dilated RV pushes pericardium further. It further drops the RV and LV filling. This classic triad you need to remember in the RV infarction: hypotension, clear lungs, elevated JVD. In the setting of acute MI, if you have all these three, you can tell clinically on the bedside the patient has right ventricular infarction. And on top of that, if his infarction is more severe, if the RA is involved, right atrium is involved, then he might lose, loss of AV synchrony, like happens in AV block or atrial fibrillation. Then it further drops the RV preload because right atrium is also compromised. One thing that you need to know at the bedside, if right atrium is involved and right atrial pressure is higher than left atrium pressure, and if they have PFO, then they will start right to left shunting. How you know that? You give them oxygen, you cannot take their oxygen saturation up with higher level of oxygen. So unexplained hypoxia, not corrected with oxygen, always think about right to left shunt. So how do you treat them? Urgent reperfusion as soon as possible. Fluid, maintain an RV preload. If necessary, you need to do inotropic support. And sometimes you might need to pace them, maintenance of AV synchrony, and definitely avoid hypoxia and increase pressure, peak pressure that can increase PVR. And sometimes we need mechanical support because, as you mentioned earlier, that if you could support for a few days, RV recovers very quickly. And some mechanical support I briefly show you, we call protic duo. They can insert through the jugular vein, and right ventricular impeller that then you can insert from the right femoral vein. It goes to the pulmonary artery and pumps the blood to the pulmonary artery, sparing the RV. And sometimes they need IV support if the patient is severe cardiogenic shock with RV infarct. You do left-sided impeller and also right-sided impeller. Let's talk about the next topic, LV aneurysm. It occurs in less than 5% of patients with STEMI, and it frequently happens with anterior STEMI, but definitely as we analyze the data recently, there's prompt reperfusion we're doing, we see the significance of the incidences getting much lower, but still a lot of aneurysm is still we see for the delay of the care if the patient comes late with this acute MI. And I'll show you this MRI. You can see that wide-based aneurysm, and they have all the layers of the myocardium. It's very wide-based, all the layers. That distinguishes the true aneurysm from pseudoaneurysm, because true aneurysm has all the layers of the myocardium and they're wide-necked. The main problem with the aneurysm happens that definitely it's a nidus for arrhythmia because scar tissue forms in this dyskinetic area. It can form blood clot, can cause stroke. So you should be able to diagnose that and either echo or cardiac MRI. Next topic, I'll go forward with ischemic mitral regurgitation. That's one of the complication, unruptured complication of MI. Let's focus on this picture. As for example, the patient had MI in the RC distribution and the posteromedial area, a papillary muscle here. So if you had infarct here, the papillary muscles gets pushed to the apex and laterally. What happens if the papillary muscle gets pushed apically and laterally? The chordae gets retracted. The chordae that gets attached to the mitral valve leaflet, it pulls the mitral leaflet laterally and apically. As we see that, I'm going to show another picture, actually. Let's play this video. Look at that, the posterior leaflet is kind of tethered here because patient is ischemic in this area, posteromedial papillary muscles is pulling that posterior leaflet to this direction. So when the mitral valve, both leaflets should coincide together, but the posterior leaflet, if it is tethered, it just stays above and the mitral valve falls behind, behind that, and there's a hole, and that causes significant regurgitation. As we see here, a lot of regurgitation, and that is directed posteriorly. The difference between this eccentric jet from mitral regurgitation, from papillary muscle dysfunction, and from like mitral valve prolapse, because the jet is going to be directed to the same area which leaflet is involved. If the posterior leaflet involved, then in ischemic mitral regurgitation, jet is directed posteriorly. On the other hand, if it is posterior mitral valve prolapse, then jet will be directed anteriorly. That's a difference. You listen to the patients. If you hear anterior direction in the mitral valve prolapse, then posterior mitral valve involved. But it's ischemic regurgitation. If it is posteriorly directed jet, then most likely posteromedial papillary muscle dysfunction going on with ischemic mitral regurgitation. So definitely how we treat them, prompt reperfusion is the best way. Sometimes if there's a lot of volume overload, you can do diuretics, but definitely afterload reducer is one of the major treatment, but don't put in anything that can increase the afterload. If the blood pressure drops, choose afterload reducer, sodium nitroprusside, rather than putting on then pure afterload increased medication that will cause the mitral regurgitation worse. The more the mitral regurgitation post-MI, we know that worse the long-term prognosis. This type of patients end up having secondary mitral regurgitation dilatation of the LV, and their prognosis is worse. Let's take another case. 73-year-old man presents to ED with chest pain for about an hour, and we see that ECG. Definitely there is significant ST elevation in anterior leads. And patient went to the cath lab, had a stent, but there's no reflow phenomena. It means that there's no TME3 flow, there's sluggish flow, and normally it happens when there's distal embolization or significant distal microvascular dysfunction. So he went to the CCEO. Shortly after he came to the CCEO, he developed short of breath, but no chest pain, short of breath. His heart rate is 110, blood pressure is 80 over 60, lungs have crackles at both bases. The patient is actually sitting, he cannot lie down, and he has a cardiac examination shows a new loud late systolic murmur. What is the next best step to do the diagnosis of this patient in this condition? His chest X-ray is going to help. Start echocardiogram, probably the best option here, because you need to know what's going on, either with the valve or any rupture going on, VSD going on. PA catheter, it might help you to assess the hemodynamics, but that's not the first thing you need to do. Or you're worried about the patient needs another angiogram because the LED stent is not working. But as we know, the patient did not have any chest pain and the ECG did not show any further ST elevation or ST depression. There's a resolution of ST changes. So probably nothing going on in that part. So you need to look at a stat echo and find out what's going on with this patient. So echocardiogram, bedside echocardiogram is a significant tool to understand the complications of MI, and our fellows and residents, they should know how to do that at bedside. And look at that here, what we have. I like to make sure that we focus on the M mode. It's kind of got out of favor, but it's still very helpful to diagnose certain situations. As I mentioned to you, the patient had late systolic murmur when you listen to him. Okay. And look at that. It is through the across the mitral valve. And this is the QRS is the systole, right? And this systole happening here is contraction going on. Mitral valve should be closed that time. But look at that, mitral valve is open. And the early systolic opening of the mitral valve, it should be closed. It should be a straight line here. As you cardiologists, they should know that M mode in systolic phase, mitral valve should be closing, but it's opening in early phase. That gives it already the diagnosis what's going on with these patients. Systolic anterior motion of anterior mitral leaflet. That means patients has been experiencing LVOT obstruction. It's a dynamic obstruction. That's a diagnosis on the M mode. And you look at the Doppler in the LVOT area, you see the dagger-shaped velocity. And along with that, there's significant turbulence. You see that here in the LVOT. And also you see significant regurgitation jet going on also. So what is the next step in this management of the patient? The patient's blood pressure is dropping. Patient feels sick. Do you want to put the intra-aortic balloon pump to support the patient? Is it going to help in this patient? Do you want to put dobutamine infusion? Do you want to give normal saline or urgent cardiac surgery? Let's recall the presentation of the patient when he came to the ICU. He developed significant murmur. And you need to really listen to the patient, if possible, do a Valsalva, and you see the augmentation of the murmur. And you already diagnose that will give you a clue if it's a dynamic murmur going on in the LVOT area. That is similar murmur we hear in hypertrophic cardiomyopathy. So in these patients, when they have LVOT obstruction going on, definitely you do not want to give intra-aortic balloon pump. It will make it worse. Definitely, you do not want to give anything that has inotropic effect. It's going to make it worse. Patient needs volume. You need to expand the volume of the LV so that the LV obstruction gets lesser and more cardiac output can come down. And definitely, this patient is not a cardiac surgery candidate. Patient has simply LVOT obstruction that is functional that I'm going to explain later. He doesn't need any surgery. The best answer would be normal saline. And I'd like to show you one fluid dynamics video, how this systolic anterior motion happens in the LVOT obstruction. As a fluid particle goes to the smaller orifice, it really shoots up. There's a huge velocity increase, shoots up. I'd like to show you again. You see how high velocity shoots up. It creates a negative pressure behind, and that sucks in the anterior mitral leaflet towards the septum, and that we call Venturi effect. And there's a 3 component on this obstruction: eject, obstruct, and leak. When this ejection happens, and then it sucks in the anterior mitral leaflet, and there's an opening there, then it starts leaking. That's the mitral regurgitation. That's the mechanism of mitral regurgitation in dynamic LVOT obstruction that happens in, sometimes we see in significant apical MI. It's most common in apical infarct, because when the whole apex is down, anterior apical area is down, the base starts to contract extensively to compensate that, and it makes hyperdynamic obstruction at the basal area, at the anteroseptal basal area. And that makes the dynamic obstruction. Because be careful, always listen to the patients, do dynamic auscultation, and the main treatment is IV fluid and also beta blocker therapy, because you need to bring their heart rate down. Don't put the patients on dopamine to keep the pressure up. You might kill the patient, and patient will go to cardiogenic shock right away if you put them on any inotropic agents. So main treatment, as you know, that reperfusion, we did that, beta blocker therapy, avoid inotropes, and definitely no intra-aortic balloon pump. That will worsen the situation. Let's do another case. 48 years old, had inferior STEMI, and we found out 100% occlusion of the mid-RCA, and he underwent drug-eluting stent. He's doing fine, and 2 days later, he developed sudden onset severe dyspnea. He's diaphoretic, moderate respiratory distress, blood pressure is low, he's probably having cardiogenic shock here, heart rate is high, O2 saturation is 86%. You listen to the lungs, the patient has listen to the heart, very soft apical systolic murmur, but he's in flush pulmonary edema, diffused rails. Remember, post-MI, soft systolic murmur, sometimes you may not hear it, but if they have fluid in the lungs, normally they are not lying down, they're sitting up. Look at the EKG, sinus tach, but no ST elevation. Whatever ST elevation patient had is gone, is total resolution, and there's some inferior QFs are there. So clinical exam is very important on these patients. Any patients post-MI, particularly inferior MI, and the patients having short of breath, fluid buildup in the lung, and also very soft murmur, always think something going on. I'm going to come to that. And definitely the bedside echo is the key. So quickly get a bedside echo and you see what's going on here. Look at that. This structure should not be here. And look at that torrential mitral regurgitation going on. This is a papillary muscle rupture, posterior medial papillary muscle rupture. So what's the treatment on these patients? This is a true emergency. This patient's mortality rate is very high if you don't do immediate intervention. So should you put on sodium nitroprusside to decrease the afterload? Should you put on dobutamine drip? Or you want to do right heart catheterization to better assess the hemodynamics, what's going on with the patient? Or you just pick up the phone and call the surgeons. The patient needs to go to the OR right away. Or you're still worried about whether your RCA stent is still patent and you want to do repeat coronary angiogram. The right answer, you already know the diagnosis, right? You don't need any of these things. You just make a call to your surgeons that please get ready, and the OR ready, the patient needs to go to the surgery, patient has papillary muscle rupture. And for the timing, you can support with intra-aortic balloon pump or vasodilatory therapy, but the patient needs to go to the OR as soon as possible. But that's the urgent cardiac surgery is the answer for papillary muscle rupture. So it happens less than 1% of MI, and definitely it's one of the reasons, like 5 to 10% reason of cardiogenic shock. It generally occurs in 2 to 7 days post-MI. And you know that papillary muscle normally is a subendocardial structure. So it can also happen in non-STEMI, not only STEMI. And most common is posteromedial papillary muscle rupture. And I'm going to show you why. Look at this picture. Posteromedial papillary muscles get single blood supply from the PDA, and it's RCA dominant artery, so at least 70-80% of the time, because it comes from the RCA and through the PDA, it's a single artery. But anterolateral papillary muscles, they have dual blood supply, both from the LAD and the SIRC. There's less chance of rupture because at least it is getting blood supply of either one of the artery, and very unlikely the patient will have a heart attack unless they have left main problem. Unless they have heart attack in both arteries, unless they have the left main problem. So one hemodynamics I like it to know that what happens, what's the difference between acute mitral regurgitation and chronic mitral regurgitation. You see that when there's chronic mitral regurgitation, atrium is already big, highly compliant atrium, and it can accommodate as much volume as it goes. So it maintains the gradient all along, huge gradient all along the systole. It maintains the gradient, the atrium and ventricle. So you hear the hollow systolic murmur. But in acute mitral regurgitation, you see the atrium is small, it's non-compliant. So blood gushes to the atrium and it stops because atrium is not that big, it cannot hold that much blood. So this gradient quickly normalizes. So you hear very short murmur, and it's a decrescendo murmur, very short. Sometimes it's faint, you might not be able to hear it. So definitely echo is the answer. If any patient post-MI having very short of breath and flash pulmonary edema, make sure the patient does not have papillary muscle rupture or severe papillary muscle dysfunction. So we know they need urgent surgery. We talked about you can stabilize it intramurally with intra-aortic balloon pump. And mortality is significant, about 20%. The surgeons really don't like to do that, but you tell them the patient is accepting the risk of 20%. If he goes through the surgery, the overall survival and EF will do better. Definitely, mitral valve surgery is most important thing to do for them, despite their significant risk, about 20% mortality risk. So since we started the rupture complications of MI, let's talk about another case. A 68-year-old woman brought to the hospital with one-day history of short of breath and chest pain. She has history of hypertension, chronic kidney disease, and schizophrenia. You know that. What does it mean? Do an EKG, and patient has huge anterior ST elevation MI. And offer her heart catheterization. And she politely declines cardiac catheterization. She doesn't want to do it and want to be managed conservatively. So she's still receiving aspirin, clopidogrel, anticoagulation, beta blocker, furosemide, the normal regimen. On day 4, you decide to discharge the patient home. And before that, she develops acute short of breath. And luckily, good thing that you did not discharge the patient then. She's very anxious, diaphoretic, tachypneic, blood pressure is on the low side, 92/70, pulse is 118, lungs are clear. And you listen to the patient, always listen to the patient. You hear a very harsh systolic murmur at the left sternal border area, and put your hand, you feel a palpable trail. A loud pulmonary component of S2 because of more volume going through the pulmonary valve. And there's S3 gallopy here. And this is a bedside diagnosis. You should be able to diagnose right now what's going on with the patient. You don't need the echo, but definitely do the echo to confirm that. But make sure you do the examination. If you hear harsh systolic murmur, palpable thrill, and pulmonary component is loud with S2, you know the diagnosis. You should be able to diagnose right now. But let's look at the next picture. So what you need to do, the echo, you're planning to do that. What it will show, you don't need the echo for that, but still you know what's going to show is going to show a VSD. No papillary muscle rupture. Because with papillary muscle rupture, the patient will have lungs full of fluid. The patient has clear lungs. All right. And anterior femoral rupture, patient will be in tamponade or probably will die. Large LAD fistula will not behave that way, definitely not enterocameral fistula. So you do an echocardiogram, and let's see what you see. You see a defect here in the inferior basal area, a defect here. And you do a color flow. You see, color flow is crossing the interventricular septum. So VSD rupture occurs at margin of the necrotic and healthy myocardium. And anterior MI, it happens about 50%, and also about 50% with inferior MI. When it happens with the anterior MI, defect in apical septum, because if there's a wraparound LAD, and if it happens with the inferior MI, most commonly is basal inferior area. But if it happens in conjunction with the RV Infarct, their prognosis is worse. Once again, I remind you, if you hear a harsh systolic murmur with a thrill, and it is a VSD, and pulmonary congestion is unusual, they will not have, pulmonary edema, will not have pulmonary edema. So let's define quickly that papillary muscle rupture and VSD. Patient lying flat and has a thrill, it is a VSD. The patient is sitting upright and short of breath, it is acute mitral regurgitation from papillary muscle rupture. And you can definitely get a quick echo to diagnose that. So treatment of VSD, definitely you do inotropic support if the blood pressure drops. Afterload reducer with nitroprusside could help you to reduce the shunt from left to right. Intra-aortic balloon pump you could use, but definitive treatment is surgery, emergent surgery. Surgeons don't like it, particularly the inferior MI, because it's a very fragile area. But if without that, patient will die because surgical mortality is, despite that surgical mortality is very high, but if you can get through that, the patient will survive and have pretty much normal life. Let's do another case. A 76-year-old woman presented to ED with 3-year history of indigestion. A lot of time we think that chest pain is indigestion, so you need to listen to the patient. ECG shows definitely the ST elevation in inferior leads. And look at that, there are some Q waves. In inferior leads already. And we decide, and the patient, he's a large set body habitus. So we try to do a contrast study with the patient, but it's still very difficult to see. And we did a CT scan with contrast, and let's look at the film. And you see this infrabasal area, there's a small hole, and it's contained rupture. We call it contained rupture in the pericardial space. It's not full tamponade, but it's a contained rupture. That's a classic example of pseudoaneurysm. The small neck, but the whole myocardium is interrupted, and only the outer wall is the pericardium. That's called pseudoaneurysm. Pseudoaneurysm, how it looks like in the CT scan, cardiac CT with contrast. So definitely it is not a pericardial cyst. It's not a VSD because we didn't see communication between two cardiac chambers, left or right. It's just in the pericardial space. So it is a left ventricular pseudoaneurysm. So next step would be, how do you treat those patients? Definitely urgent cardiac surgery. Otherwise, the patient might go to frank tamponade and have free wall rupture with the free wall rupture. So the patient needs to go urgent cardiac surgery if you suspect the patient has pseudoaneurysm. So remember that free wall rupture, always if you see an elderly woman presents with first anterior MI, think about that, just keep in mind. Let's do another case. 45-year-old man presents with chest pain to ED. It describes left-sided discomfort that radiates to his left shoulder and is also deep breaths. And he gives the history that he had a STEMI 2 weeks earlier and got a stent in the left circumflex artery. The patient's coming with chest pain that's pleuritic in nature. With deep breath, it hurts. And definitely he sits forward, we cannot lie flat. And he had a STEMI 2 weeks earlier. And his current medications, these are good medications, aspirin, ticagrelor, atorvastatin, metoprolol. But it white cell and ECG was obtained. I'll show you the ECG. White cells about 12,000. That's the abnormality we see. And ECG looks like that. There's some ST elevation going on. Inferior leads, anterolateral leads everywhere. But look at the EKG carefully. You see the PR depression in all leads except for the AVR, this upright PR. This type of ECG with the clinical scenario is pathognomonic for acute pericarditis. The patient had delayed pericarditis that he called Dressler syndrome, post-MI. It's one of the complications of the pericardial space. How are you going to treat these patients? Like aspirin. In post-MI patients, try to avoid the non-steroidal or prednisone. Definitely high-dose aspirin is the treatment of choice in this patient.
Can I interrupt you for a second?
Yes.
Yeah. So fantastic that you presented this case, because there is a question. I'm going to link it up with it.
Mm-hmm.
And the question was from Dr. Saifur Rahman. How to differentiate between pericarditis and recurrent MI in a post-MI patient, exactly the case that you were describing. And that's the question that he asks. My question would be that you know the diagnosis, you know the PR, but if let's say I did not pay attention to PR, but I saw diffuse ST elevation in multiple leads, what can I do before doing anything else? I mean, if I give heparin in pericarditis, they may have tamponade, right? If I miss acute coronary syndrome, then I am harming the patient. What can I do at this point, investigation-wise, before I make a decision?
First thing, definitely examine the patient. Yes, the patient's chest pain, the nature of the chest pain, okay? They are pleuritic type mostly. And second thing, this type of patients, if you see in the ER or in office, the patient cannot lie flat. Because when the patient lies flat, it stretches the pericardium. It makes it worse, the pain. They normally sit up and sit forward. And definitely that's a clinical diagnosis, really. And look at the pattern of the EKG, as we mentioned about PR depression and concave type ST elevation, diffuse ST elevation, and upright PR. Next step, you might just get an echo. Just look at that, whether there's any new wall motion problem or anything going on. If there's no new wall motion problem, unlikely it's an acute MI going on. And if you have any previous echo, if this previous wall motion, compare that wall motion was old or new, definitely these are things you could do, but it's mostly clinical diagnosis. And Dr. you want to add something? Yeah. Mm-hmm.
Yes. No, I just want to reiterate what Aziz said. I mean, the most important part is that this patient has ST elevation in multiple leads. That's kind of interesting. To have acute MI in multiple leads is possible, but not very common.
That's correct.
Second, the clinical picture is important. And then echocardiogram is available everywhere. And sometimes these patients can have elevated troponin. That doesn't help that much. Right, Aziz?
Yes, and I'd like to add a point, because the patient had recent MI like 2 weeks ago. He still will have some residual troponin elevation there. It's coming down, but it might still hang around a couple of weeks.
Yes, and so echocardiogram is the most important. Now, if Aziz mentioned one thing that you may not have paid attention, that if this patient never had an MI, there will be no wall motion abnormality. But if patient had prior MI, then what you do, you compare with the old echo.
Old echo.
Is there any new area of wall motion? So the echocardiogram will be the most crucial test at this point to make a decision. Thanks, Aziz.
You're welcome. Thank you. Let's go to the next slide. We talked about ruptured complication. We talked about unruptured complication. Let's focus on arrhythmia complication. Definitely tachyarrhythmia. That's Dr. Rafiq Bhai's favorite subject. And it could be tachy or bradyarrhythmias. But definitely in the tachyarrhythmias, ventricular arrhythmia is most common because sometimes patients present with a V5 cardiac arrest with MI. Or it could be supraventricular tachycardia, SVT, AFib is very common. Or it could be bradyarrhythmias, particularly if the patient comes mostly commonly, if they come with inferior MI, they mostly commonly have conduction disease in the AV node. Or if they have severe anterior MI, they can have intrahesion block. So conduction abnormalities are also complications of, we call electrical complications of MI. And let's give a case scenario. 65 years old man presents with inferior STEMI and had a drug-eluting stent in proximal RCA for 100% occlusion. During the procedure, he develops wide complex bradycardia. Rate was 30-40. And the patient definitely received in the cath lab atropine. It didn't work. Then they put a temporary pacemaker. And following the procedure, the patient chest pain resolved. And he did fine. He troponin definitely 52, but he already had an MI. He got aspirin, ticagrelor, lisinopril. He's on good medications. On the next day, you examine the patient. Blood pressure is okay. Heart rate is 80, but with pace rhythm. So you decided whether you can take the temporary pacer off. So you turn off the pacemaker and you see the ECG. It's still patient's high-grade block going on. Okay. So the question right now comes along. Look at the ECG, and I'll give you the questions. So what are you going to do on the second day to make decision about the patient? Are you going to put a permanent pacemaker to the patient? Or you want to put dopamine or isoproterenol to stimulate the rate? Or call Dr. Rafiq Ahmed to do an EP study to see if there's any significant conduction abnormality going on, he needs a permanent pacemaker or not. Or just wait, watch the patient, and maybe he will recover, continue the temporary pacemaker. Or if you have certain concern about that, you put a stent, it probably closed off, you might need to go and repeat angiogram. These type of patients, I like to focus on that. You'll see very commonly with inferior MI. As you remember that if the right coronary artery also supplies the AV node, and the problem is that this type of conduction abnormality arrhythmia happens mostly in the AV node if it's from the right side, rarely in the infrahesion area. And they do recover. It's called basal gyrus reflex that we have. Sometimes they are severely bradycardic, but if you can watch out these patients few days, a lot of patients, if they're stable rhythm, like 40 heart rate, but they're stable hemodynamically, you don't have to even put a temporary pacemaker. You just watch them 2-3 days, they'll recover. But if the patient does not recover after 3-4 days, then you have to make a decision whether the patient has infrahesion block. Normally, they are wide complex in infrahesion block, but there's a clue to that. And if you give atropine, if it's infrahesion block, it might make it worse. Because if it's an AV nodal block, then atropine might accelerate the heart rate. So you can test the patient with the atropine and see if you can increase the heart rate. And Dr. Rafiq Ahmed can comment on that a little bit more. But these are things you just watch the patient and just continue the temporary pacemaker for now and watch few days. Patient will probably, most likely, will not need any pacemaker. All right, so I talked about that, these things. Let's go to the next slide. If the patient presents with STEMI, and most commonly they have cardiac arrest, you can assume that a VT or V5 arrest happening. And one thing that I like to mention, that when you deal with the patients with cardiac arrest, definitely you defibrillate the patient, you do emergency vascularization, revascularization of the artery, culprit artery. But don't forget that target temperature management, because this is very important, because all the data shows that definitely decreases neurologic injury and mortality. How you cool the patients, you need to lower the body temperature. Normally it's 32 to 36 degrees centigrade, or 48 hours you need to do that. A therapeutic hypothermia, we call it 32 to 34 degrees centigrade. You can give cold saline, 1 to 2 liter, ice packs, cooling blankets, and definitely need to sedate the patients to reduce the shivering, because that's very important that you need to do it right away as soon as possible. And actually, you can send the patient to the cath lab with the cooling blanket on. It's not a problem with that. They can still do the cath with the cooling blanket on. So you need to really save the brain to have anoxic brain injury to this patient. And always look at that. If you're anytime VT, VFib, definitely do defibrillation, correct the electrolytes, acid-base abnormality, treat ongoing ischemia, treat pump failure. But if they call you that, doctor, the patient is having frequent PVCs on the monitor, what to do? Definitely do not suppress the patient PVC with class 1 medications from the CAS trial, as I know that it causes more harm. Beta blocker would be the drug of the choice, but not class 1C. And when you put the ICD, sometimes they can ask you if the patient's on VFib immediately after, during the heart attack or after the heart, within a day of the heart attack, and you revascularize the patient, you don't need anything, just give them one beta blocker. But if the patient has VT, VFib after 48 hours post-STEMI, then there's a consideration whether you need to put an ICD as a prevention. But still, you need to rule out whether the patient is not having any transient or ischemic reversible ischemia, reinfarction, or any metabolic abnormality. But within 48 hours window, that's kind of a debatable area. I think I will ask Dr. Rafiq Ahmed to comment on that. We sometimes debate to whether we'll consider serious VT. We know within 24 hours for sure we don't do anything, but in between 24 to 48 hours, there's a window. We still we do some individual management on this type of patients. And one thing I'd like to make sure, do not confuse that with primary prevention. When the patient comes with VT cardiac arrest with MI, that's you're doing secondary prevention ICD, not the primary prevention. And the primary prevention thing we talked about, there's a lot of data available, but dynamic trial, the Danish trial really gave us a very good clue when to reassess the patient. Because they studied the patient after the MI in between 6 to 40 days, an EF of less than 35%, they randomized this patient's ICD and no ICD, and definitely no difference in total mortality. That came to the guidelines when to reassess the patient post-MI to make decision whether the patient needs primary prevention later on. And that is 40 days after medically managed MI or 90 days post-PCI or CABG. You reassess the patients and then look at the EF, look at this functional, NYHA class, then you make the decision when to put primary prevention ICD. I'll conclude there. Thank you very much, and I'm open for questions.
Yes, thank you for a wonderful talk. I mean, this is a big topic, and you have done a wonderful job. And with Esa's permission, I noted down some of the questions from the audience. Is that okay, Esan? Yeah. So Aziz, I think this.
Yes, sir, sure, sir.
Yeah, this question relates to your case number 8 that you presented, but a little similar. Dr. Zinat Faruqi asked a question that there is a 24-year-old female who presented with 30 minutes of chest pain. And ECG showed double surface. I don't understand the term, but I'm assuming that 2 different areas there was a ST elevation. And patient received streptokinase. And the echo showed EF of 40%. They did a cath, which did not show any obstruction. What was the cause of this ST elevation and chest pain in this patient? So can you comment on the management also?
Yes, the question right now, if you see the ST elevation, normally you expect in the single question about the surface. I also don't understand the terminology, as you mentioned. I assume that is 2 different areas, 2 different artery territory, right?
I think so. I mean, it's probably inferior and probably anterolateral multiple surface.
Yes, and the question right now, if it's ST, normally we see ST elevation if it is due to plaque rupture in one artery distribution, normally, unless it's a left main disease that you can see LAD and left SARC both territories, okay? But it can happen if you have, we call it spasm of the artery, or stress-induced cardiomyopathy, okay? Because the reason is, and you already told me that the patient had normal coronaries. So I assumed it has to be secondary cause, secondary MI, not the primary plaque rupture MI. And you look at the differential diagnosis, and sometimes it can happen if it's a spasm of the artery, the patient's prone to spasm, but still rarely we see in all arteries spasm at the same time, but it possibly could happen. They could have transient ST elevation if the patient's, and she's very young, and there's likelihood it can happen. And sometimes we see also scarred, but you'll see that, when you do angiogram, you'll see spontaneous coronary artery dissection. This is not the case. I think it's most likely spasm. And in young people, you need to really look at if the patients are using any drugs that can potentially cause that. And the treatment is going to be, if you define it's spasm, then you might decide to give some calcium antagonist or long-acting nitrate. Those type of treatment is available. But you need to make sure you examine the patient. It's not pericarditic ST elevation, okay? Because if the patient has pleuritic type chest pain, that's totally different treatment. But if it is true, like ischemic pain that you described, and that's not due to plaque rupture, and it's two different areas, I can assume that patient might have coronary vasospasm in multiple areas, distribution that's causing that. And you can use a vasodilatory like long-acting nitrate, calcium antagonist as a treatment and a first-line treatment, and make sure the patient is not having any drug abuse. That we need to rule out first.
Thanks, Ajit. I think what I would have done with this is a 24-year-old female.
Yes, yeah.
This is a low-risk patient. So first thing is, when you see ST elevation in two surface areas, you have to consider pericarditis very seriously.
Mm-hmm. Mm-hmm.
And then I would probably, first thing I will do, get an echocardiogram. And if there is no wall motion abnormality, it is very unlikely that it is ischemia. And then the question would be to give drug like streptokinase. It's a pretty remarkable
serious drug in young people, yes. Mm-hmm.
Yes, especially if the patient is having pericarditis and I give a streptokinase. So I think I would have done an echocardiogram on this patient, as Aziz mentioned before. And if there is no wall motion abnormality, then before giving streptokinase, we have to think seriously about this patient. And as Aziz mentioned, I have seen one case in many years that had spasm of both right coronary artery and LAD, but that patient has diffuse ST depression, not elevation. Even for the spasm, it usually is territorial. I mean, you see Yes. Mm-hmm. I lived in Japan, and in Japan, there is a lot of vasospastic angina, and they have ST elevation. So I think before giving streptokinase, I would have done an echocardiogram, look at wall motion. If there is no wall motion abnormality, and I still have doubt, I would probably go for angiogram rather than giving streptokinase, because angiogram, I can control that anticoagulation. I can do an angiogram without anticoagulation, and just to rule out that possibility. Thank you. So I think there is another question, a couple of questions. One is, what is the maximum time limit for PCI in the setting of acute MI?
Yes, actually, I talked yesterday, but I'll definitely repeat that. It's a very important point to make. As all European guidelines and US ACC and American Heart Association guidelines, there's two very well-established guidelines. And it came from all the data we had before. Main thing is that you need to find out first medical professional contact. That's your clock time. When the patient comes, either EMS or a nurse or physician contact, that's the first time. And when the patient comes to the physician in the hospital, that's the clock starts, okay? And then within 10 minutes, you need to do the ECG, and it should be interpreted, not only examination of the patient's ECG done, interpreted, and you made the call with the patient as ST elevation. If you are PCI capable hospital, take him to the cath lab. The patient needs to be going to the cath lab as soon as possible, okay? If you are not PCI capable hospital, you are thinking about doing thrombolytic therapy, fibrinolytic therapy, then it has to be done ideally within 30 minutes, okay? And if you think, no, you can transfer the patient to a PCI hospital, then you count the time that whether it could be done door to balloon time, not only going to the hospital, balloon time less than 120 minutes, then you should transfer the patient to PCI hospital, all right? And if it is more than 120 minutes and the patient is eligible for thrombolytic therapy, you should give the thrombolytic therapy. And if the patient is unstable, hemodynamically unstable, despite that you give the thrombolytic therapy, patients having hemodynamic compromise, a lot of non-sustained VTs, there's no ST resolution, immediately transfer the patient to PCI hospital. It doesn't matter what time it takes. Even if you give the patient thrombolytic therapy, the patient is stable, and there's some ST resolution happen. All the data shows the patient will benefit for PCI intervention. Despite that, you got the patient got the thrombolytic therapy, and ideally patient has resolution of the thrombus. Then you transfer the patient in between 3 to 24 hours to the PCI capable hospital and get an angiogram done and to open up that artery. And that's the current recommendation we have. Yes, borderline into remember less than 120 minutes if you're not in PCI capable hospital.
Thank you. So there is two more questions. This is from Dr. Saifur Rahman. I think it falls into the management of chronic coronary artery disease. Is PCI needed for old myocardial infarction?
First of all, old myocardial infarction, if the patient is asymptomatic, okay, patients walking, exercising, no chest pain or anything, you see Q waves in the MI, you do an echocardiogram. That's probably the most important thing to do rather than the stress test. And you see the LV function. If the LV function is okay, then even if it's not okay, like there's some certain damage to the myocardium, you see this wall motion problem, but the patient not having symptoms and the patient is exercising, you do a treadmill, a nuclear test or whatever test, you can do a test to define what's the extent of ischemia. But if he does just routine treadmill, no problem, there's no need to go for the testing. Just treat them medically, they do better. As we know, the Courage trial, that if you have like significant disease, even multivessel disease, 70, 80%, but if they're asymptomatic, and they randomize those patients, the one group got angioplasty with stent, another group just optimal medical therapy and risk factor management. Both of them had optimal medical therapy. They did fairly well even after 6 years. Unless the patient having active angina, then there's no need to go for that if the patient is stable despite the patient had old MI, because there's no significant mortality benefit down there. But if there's LV dysfunction, definitely there's concern about that. And if they're symptomatic, then you go and treat the patients, make sure the good heart failure regimen, make sure ACE inhibitor, aldosterone, those type of medication, aldosterone antagonist, those type of medication, you need to have very optimal medical management. They do better. There's no need to go for heart catheterization unless that patient is symptomatic.
So I think there's another question from Dr. Saifram. The question I don't understand as much, but I get the summary of it. Mm-hmm. How to determine if in a patient with ischemic heart disease, there is irreversible ischemia. I don't believe there is any term called irreversible ischemia, but I think the more appropriate question would be, is a territory have ischemia or not? And yes, question is how to manage that.
Yes, as for example, actually, I do a lot of nuclear study myself, and let me give some depth of that. When you have a heart attack, you damage the muscles, right? Unless you have reperfused quickly. So otherwise, if you did not get reperfused, there's some damage to the muscle, there's a scar tissue formation. So when you call it reversible ischemia or fixed defect, okay, that's the right terminology we should use. We compare the resting picture and the stress picture, okay? If you see certain area not getting blood supply on the resting, and also on the stress picture, similar area not getting enough blood supply by nuclear testing, an imaging study, any type of imaging study, we call it fixed defect. That means there's a scar tissue, and that is not going to improve even if you open up the artery. Just leave it alone, because there's no change when you stress the patient. But when you stress the patient, if you see more area in jeopardy, like 35% area in the jeopardy, and the resting picture not like 10%, so there's significant area at risk, there's 20% extra muscle is in jeopardy, then you might go in and try to open up, you might improve circulation in that area, that you might regain some function. And in certain situations, we do called viability study, like if there's significant area damage, like anterior wall apex is akinetic or dyskinetic, and you're thinking about the patient has tight lesion in the LAD, whether you need to open it up, then it's a serious issue, because if the area is dead, there's no reason to open up. You're not going to improve anything on this patient. There's no improvement in mortality or EF benefit with that. Multiple randomized trial has shown that. But how do you determine that? You can do by just nuclear stress test, FDG PET stress test, or MRI of the PET MRI. You can look at that area of the myocardium, whether they are viable. Viable myocardium is better determined by the FDG testing, because if you see certain area, the uptake of the FDG and the light up on that, that means that area is still viable, but they're not contracting well, but they're still viable. So FDG is probably the best one here. So if you can see the viable myocardium, there's a reason to open up that artery. There's a good chance that you might improve that, because the muscle in that area is hibernating. We call hibernating myocardium. That can improve in the long run if you open up that artery.
Ajay, if there is no PET, you can do viability with nuclear stress test?
Yes. And actually old thallium does that. We call, late redistribution or just SPECT. You can do that. Yes, in the nuclear stress, you can do that. Or CT SPECT, you can do that.
Okay. So the reason I asked the question, there is a reason for it. We have nuclear stress test available in Bangladesh. I know Bangabandhu Sheikh Mujib Medical University, they do it. And I do not know other places whether they're doing it or not. But that means the technology is available in Bangladesh. And I come to these forums and I promote Bangladesh. That's my passion. And I would like all of you to find out about nuclear stress test. There is a significant role. I'm going to summarize what Aziz said as a non-intervention person. If somebody comes with an old myocardial infarction and the area that is involved, the muscle is dead, there is no point of trying to go and open that vessel or do anything about it. On the other hand, if the muscle in that area is viable, then you have a benefit of opening that up. And a nuclear stress test will be is actually the way to do. If it is my body, that's what I would want to be done. So please remember this. Not all vessel needs to be opened up. So that's important. So we'll
Another point I'd like to make, Rafiq Bhai, there's another way to do it, like simply echo, like a stress echo, dobutamine. Another way to look at the viable myocardium. Because if you do dobutamine at low dose, like 2.5 microgram at low dose, and you see not much improvement of that area, wall motion. But if you see like you go to 5 microgram and you see that there's some movement there, the wall motion, little bit movement going on. But if you go higher, like 10 or 20 or above 20, then it gets dyskinetic again. That that when you do the low dose dobutamine, and that you see some viability in that area, you see a slight contraction, but you go to higher dose, it becomes ischemic. That's how you differentiate that. It's a hibernating myocardium is still there and they will benefit. So echocardiogram is another tool to do that with dobutamine echo. Like we start with low dose, medium dose, and high dose. If the low dose makes it more movement in that area, you see some contraction going on, and high dose becomes ischemic. That means the patient, that area is hibernating and they can improve with revascularization. So echo is another tool.
Yeah, Aziz, you bring a very important point, and we talked about it. You see, nuclear stress test, the problem of nuclear stress test is the isotope has to be made and has to be used within a certain period of time. You cannot keep it for 5 days, 6 days. Bangladesh echo is available everywhere, even in the subdivisional towns. And to do stress echocardiography will be the best modality. Only thing lacking is public cardiologist awareness of the stress and the desire to do this test. I think this will be one test that can be done everywhere, even the subdivisional towns in Bangladesh. And it's a low-risk procedure. It's a very low-tech procedure. So I would encourage that this is looked into more to look. So now I think, what time are we finishing, Hassan?
Sir, another 10 minutes.
10 minutes, okay. We have two more questions. One is, post-CABG, is coronary angiography needed for checkup? I think what, this is from Shuman Kumar, and I think what probably he's trying to understand that what will be a follow-up for post-CABG patient. And he specifically asked, is coronary angiography needed?
Now, normally post-CABG, we don't do routine angiogram. Absolutely not. It's not indicated. but these patients used to be followed at least once a year by a cardiologist. And we do not do a stress test every year. Okay, what we do have a very good communication with the patient of the risk factor management and how the patient needs to do exercise 30 to 40 minutes a day, at least 5 days a week. They give us more information on what's going on with your coronary artery status. Because if the patient exercises 5 days a week and you have very good communication and establish a good relationship with the patient, you get more information than doing stress test every year that doesn't do anything and actually waste of money. So when you ask them whether they feel any symptoms, like if they're feeling any chest tightness, pressure, or unusual short of breath, certainly that's an indication you need to go forward. Okay. And then we bring them in. We might do probably after 2 years. Initially, we do post bypass. We do initial stress tests that for different purpose. After the stress test, the purpose is to enroll them in cardiac rehab program. And that's a different need for that. But routine follow-up stress is not necessary. We do sometimes after 2 years and maybe after 3 years, we do that. And when it goes above 5 years of period of bypass, then we follow closely. As we understand, the grafts, arterial grafts last longer, but the vein graft average 7 to 10 years, maybe sooner if the patient really doesn't follow any risk factor modification. So after 5 years, you get more serious, then you can do more close follow-up, maybe yearly, at least routine stress test, and see how they do routine treadmill I'm talking about. You don't have to have nuclear stress test for that. But if you have certain suspicion that the patient is having ischemia going on, then you might add imaging modality like nuclear stress test or stress echo to see whether there's any certain area of distribution of ischemia going on. Because when patient had bypass, you might be more interested to know not only ischemia, but what region is the patient having ischemia. Whether there's an LED graft is compromised, that's more serious problem. Vein graft we expect to be compromised after 7 to 10 years. Unless they're symptomatic, we do not go do angiogram to look at the artery vein graft. Because if they're symptomatic, then only then we go. If the patient's walking on a treadmill having chest pain, then only then you do angiogram to find out anything you can do. Otherwise, leave them alone, do maximum medical management and risk factor modification.
Thank you, Aziz. I think the most important is non-invasive evaluation is very important. And that brings us to the point that you need non-invasive cardiologist for this. Not all patient has to be, vessel has to be opened up. I mean, and the other thing, in some patients, we have to make a decision that they will have to live with some angina. Is that right, Aziz?
Yes. Let me tell you, you have to imagine that when the patient had bypass graft, right? You already utilized all 3 or 4 grafts. There's not much left on the patient if you want to do something. And those vessels, the vein grafts, are very fragile when you intervene. They have calcified grafts normally. And when you put a stent or something, they tend to break off easily and do distal embolization. So, and to put a stent is not that easy on the vein graft. And that sometimes, depending on what area the graft insertion point problem, then at the ostium and the insertion point, it's difficult to do angioplasty down there. So you need to go in and do procedure only they are symptomatic. After maximum medical management, you try to manage them medically first. And if you feel like they're having unstable angina and your medical therapy failing, then you go in and do the angiogram and see if you can open up that vein graft.
Thank you. So the last question, I mean, the question was about antiplatelet. Like our person who asked the question, I am also confused time to time. Clopidogrel, I think I understand this binds irreversibly to the platelet. Ticagrelor binds reversibly, and there is Pressagrel. Question was, when to use which one and how long for?
Yes. As for example, like definitely clopidogrel, we know more. Ticagrelor is newer, but it's at least few years already. We know that. If you compare that, clopidogrel, ticagrelor, and prasugrel, definitely the vessel reocclusion rate is much less with the ticagrelor. Ticagrelor does better with the reocclusion of the stents, but it has slight increased risk of bleeding and side effects of the ticagrelor, like a lot of, some patients feel very short of breath, tired, fatigue feeling. Prasugrel, you know that it is better than a little bit of clopidogrel, but there's a significant limitation in the prasugrel because increased risk of intracranial problem and bleeding. because you cannot use that patient with previous history of stroke and TIA. So prasugrel is not a good choice for them. And clopidogrel definitely is most commonly used medication, unless they have genetic problem with that. As we used to do biomarker and do some genetic testing. But overall, you can use either one, except for those circumstances that if the patient had a stroke or TIA, don't use that. If the patient is high risk patient, then maybe for thrombosis, then you might use ticagrelor, or probably better than clopidogrel. That's the way I would say it. And general common patients, probably just clopidogrel is fine.
Thank you. Thank you very much. I think we are done with the questions. I think this was a wonderful session. Ehsan, if you want to say something.
গতকালকে আসলে আমরা 50% কোশ্চেন আনসার করতে পারিনি, কারণ বেসিক পার্টে আমার একটা কোশ্চেন স্যার একটু করতে হচ্ছে স্যার, এটা অনেকেই করেছেন। ফার্স্ট কোশ্চেন, যদি কোনো সিএলডি পেশেন্ট যদি এমআই নিয়ে আসে, তার ক্ষেত্রে স্ট্যাটিনস এর ইউজ কিভাবে করব? আর আরেকটা গ্রুপের কোশ্চেন ছিল যে এমআই এর ক্ষেত্রে ভাস্টেটিন, রোসোভাস্টেটিন বা ভাস্টেটিনের ক্ষেত্রে কোনটা চয়েস করব, এরকম কোনো গাইডলাইন আছে কিনা?
আচ্ছা, আমার প্রথম প্রশ্নটা আমি একটু বুঝতে পারিনি যে কি কোন পেশেন্ট এমআই নিয়ে আসছে, একটু আবার বলেন তো প্রথম প্রশ্নটা।
সিএলডি, ক্রনিক লিভার ডিজিজ স্যার, ক্রনিক লিভার ডিজিজ বা হেপাটিক ফেলিওর পেশেন্ট।
হ্যাঁ, না এখন জিনিসটা হচ্ছে কি, if they have chronic liver disease, still you need to open up the artery. There's no question on that. Primary angioplasty, the preferable choice. Okay. And this second question, which statin should be used? The data we have, definitely more data we have, high intensity statin is on the atorvastatin and rosuvastatin. Definitely there's some new generation, MUBAP group data are available right now, but they're very costly. We're not going to get there because they're mostly IV medication. First, let's talk about normal statins. Definitely atorvastatin or rosuvastatin. The Miracle trial and the Prove It trial, they have high dose statin, atorvastatin, they tested that. And that would be a very good choice. Just use 80 milligram of atorvastatin. That's commonly used in the United States that we do. 80 milligram of atorvastatin when the patient hits the door with acute MI. Later on, you can bring it down when you see the patients in the office. But initial high dose, don't worry about the cholesterol level because of the anti-inflammatory effect of the statin that we see in the vulnerable plaque when the plaque ruptures or certain other areas of the other plaques.
I think one of the things that
thank you very much.
Just one comment about lipid. I think we should have a talk on hyperlipidemia. It's very, very important topic. So yes, and if we could arrange it, that would be great.
Thank you very much, Dr. Azizul Hoque, sir. Before going to our chairperson, we'd like to hear something from you about your last 2 days experience with PD physicians.
Actually, I think it's a nice forum. And as Dr. Rafiq Ahmed said, and we do have our earnest desire to share our expertise, because we are teaching in Emory, our young physicians, our fellows. Definitely like to do that to train our young physicians in Bangladesh so that they can give better care to our people, all right? And I prefer like hands-on training, more practical approach, the patient coming in certain situation, what to do. Because I encourage our young physicians, I see a lot of comments from them, and they're very eager to learn and very smart doctors we have. We just need to nurture their passion. And I think we need to also refine our educational, how do we do medical education down there to give more practical approaches for them, not only just to pass the test with theoretical knowledge. Because I'm just letting you know, I have my own relative, just finished Dhaka Medical College a couple of years ago. And, they know a lot of things, but when you ask very specific questions, they're in trouble. You understand that? So we need to make sure the hands-on training, kind of difficult to do online. Definitely, normally we sit down across the table, we discuss patients and how to treat those patients, and what is the guidelines, what is the data on that, why you treat that, and definitely physical exam. As my first day in my rotation, I asked my fellows and my residents to make sure you know how to assess the fluid status. learn the JVD. That first thing I ask them, because most of my patients in heart failure, half of them are heart failure patients in the cardiology team. They need to know how to assess the fluid status, when to start Lasix, when to stop it, what are the criteria to stop it, what to look for that. Those are the things. Hands-on training is more important, and we'd be happy to participate in this, process. And I know Dr. Rafiq Ahmed, he was my attending. I had him long time ago, and we have very good relationship. We have good passion for that, and I think we should do some forums of that, and that would be probably helpful. And we need some, help from our Bangladeshi community doctors so that we can make a, big certain established way these physicians could go and get help. You understand? Because, we have limitation from outside to do that. But if you have some local physicians who are involved in that mindset, that might be very helpful for the young physicians to turn themselves very effective physicians. Because our goal to treat patients to save lives. Because as I was told, when you are a physician, you don't belong to yourself, you belong to people. That philosophical mind we need to have as a physician, just not to make money, to help people. That's my bottom line. Thank you.
Thank you, Dr. Azizul Hoque, sir. স্যার, আমি আপনার কনক্লুশন স্পিচে যাওয়ার আগে স্যার আপনাকে বিশেষভাবে আমাদের চেয়ারপারসন স্যারকে ধন্যবাদ দিতেই হবে যে ডক্টর আজিজুল হক স্যারকে আমাদের মাঝে ইন্ট্রোডিউস করে দেওয়ার জন্য, এবং স্যারের কাছে আমাদের মানে অশেষ কৃতজ্ঞতা। স্যার প্রথমে চৌধুরী এইচ হাসান স্যারকে আমাদের মাঝে ইন্ট্রোডিউস করালেন, তারপর ডক্টর আজিজুল হক স্যারকে ইন্ট্রোডিউস করালেন। তার প্রথমে আমি আরেকটু ধন্যবাদ দিয়ে নিব আমাদের প্রফেসর মাহমুদ হাসান স্যারকে, কারণ প্রফেসর মাহমুদ হাসান স্যার আমাদের মাঝে ইন্ট্রোডিউস করেছেন ডক্টর রফিক আহমেদ স্যারকে। তো আমি আজকের সেশনটি কনক্লুড করার জন্য আমাদের আজকের সম্মানিত চেয়ারপারসন ডক্টর রফিক আহমেদ স্যারকে আহ্বান জানাচ্ছি।
Thank you. Thank you, Ehsan. Aziz, wonderful lecture, and thanks for your time. Our job is to participate. Bangladesh has come a long way, and I'm always looking at the positive side, and I think it's a tremendous job. And what I like about these lectures, that I used to give lectures in 1990s, and nobody would ask me a question, or they will ask me a question which has no relevance. But the question that I get these days from our young doctors is fantastic. That means they're studying and they're working. And I pray that you continue this path. And Bangladesh, remember, Bangladesh was the poorest country in the world in 1971. In 50 years, we are the 44th biggest economy in the world, and consecutively over many years. And that's a big, big achievement. And we will have to continue that in the medical field also. We compare with our neighboring countries, but please remember, across the board, Bangladesh's healthcare is better than India. In India, small cities may have better healthcare, some cities, but not across the board. So we are in a good path of progress. Please continue with that. And in the process, whatever we can do for us who are outside, we will do it ourselves. And thank you for giving us the opportunity to be part of it. Thanks, Ehsan, for that. Thank you, and we'll close the session here. Thank you.
Thank you.